Good morning, Carolyn Shapiro, and thank you.
You're welcome. I'm so glad that I can be your sidekick. It is a wonderful honor. Actually, the wonderful honor is having you here with us each week. Blessed we are. So I'm saying good morning to you. Good morning to the women who are coming up. Good morning to me. And yeah, we got the questions. You ready?
I'm ready.
All right. Okay. Question number 1 comes in. Dr. Rosensweet, how do you feel about progesterone drops taken under the tongue? Not troches, but actual drops. I'm a woman who has a really tough time with progesterone, and I'm just wondering your thoughts on this.
Well, I wonder what that tough time is.
Mm,
And there's lots of different reasons for a challenging time with progesterone. And most women tolerate progesterone beautifully. I mean, progesterone is far more prevalent in a young woman's body than estrogens are. So a woman is used to that biochemical called progesterone and loves it. It's so beneficial. Yet there are a certain very small 28 years of working with women in menopause. There's very, very few women who have a challenge with progesterone. And yes, it does occur. So I want to look at what those challenges are. But I first want to address the drops. If the drops are working for you, I didn't quite get the sense that they were. Bravo. Continue on them. That's great. It's a reasonable way to give progesterone. And it depends what the drops are in. I mean, I prefer the drops, if we're going to do drops, in our patented organic oils base. But whatever form you got the drops, if you're tolerating them, great. And play with the dosages. I like to see a woman maximize the amount of progesterone. That means she takes progesterone at night most commonly, although you can certainly take it in the day. It's very calming. So it can help with sleep. So taking it at night is very common. And then, if you tolerate a certain number of drops, increase the drops, drop by drop, night after night, until you wake up in the morning with symptoms of progesterone overdose. Progesterone is so calming that if you take a little bit too much at night, you're going to wake up groggy, like you took a sleeping pill or something like that. Now, drops are not my favorite form of delivering progesterone. My favorite is applying it to the skin in our certified organic oils base. That's number 1. And then number 2 is progesterone capsules can be made up, although it's absolutely far from most safe and efficacious to take estrogen or testosterone by mouth. We wouldn't want to do that. It's not the optimal way to go, for sure. And there's even risks with taking both of those by mouth. Not so for progesterone. You can take progesterone by mouth, and it's safe to do so. And it can be individualized to your body. And my favorite way to do it is give a woman 50 capsules of 75 milligrams and 30 capsules of 25 milligrams, and have her start with either 25 or 50 milligrams and gradually increase until she gets an overdose of progesterone at bedtime. This is my favorite way to do it. When you take something under the tongue, it gets so rapidly absorbed that you get this peak. Well, with progesterone, it's not that big of a deal. We don't like peaks with testosterone. We don't like peaks with estrogen. It's not the optimal way to take it, but with progesterone, it's not that big of a deal. So you get a peak, and then because you get a peak, you can get a more significant rapid fall off.
right.
And so you don't necessarily get the steady dosages. But once again, if those drops are working for you sublingual, although again, I didn't quite get that they were, bravo. Continue with the drops and even increase the drops until you go to slight overdose. So there's also troches. These are gummy-like things or gel-like things that carry the progesterone, and then you stick it under your tongue. And that's a slower delivery system than pure drops under the tongue. And there's something to be said about those as well. Some people like them. They're again not my favorite. Whatever you're doing, whether you're doing drops or you're doing troches, you're going to be swallowing some of it. So you sort of divide up the dose into that which gets absorbed under the tongue and that which is swallowed. Now, with progesterone is no big deal at all. So I just think I feel terrific about drops and troches if that's the way to go. Again, not my favorite. Favorite is topical to the skin, and second favorite is oral. But progesterone drops or troches, great. Now, I do question what the trouble is that the woman is having.
Mm-hmm.
When you're doing drops, it's unlikely that it's with overdose. And I encourage you to download our book, Happy Healthy Hormones. We list the symptoms of progesterone overdose. It would just be unlikely that overdose was her issue. Because it's hard to get the concentration up that high. And when you're administering drops, it's really hard to get the concentration up that high. So I don't think her problem is overdose. And sometimes it's with even the progesterone itself. There's a lab, Meridian Valley Lab in Washington, in Tahoma, Washington, that if you send them, I believe it's a salivary sample, they can even try and see if you've got a peculiar sensitivity to progesterone. And sometimes just changing the vehicle that the progesterone is in, like the common drops that often contain propylene glycol.
Right.
And not a favorite. Would accept it if that was the only tool that I had. But you can try different vehicles, because sometimes what the woman is having trouble with is what the progesterone or another hormone is being carried in. Because when you look at that bottle of drops, 90% of it is, or over 90% of it is actually what the progesterone is being carried in or dissolved in. So that's the first thing I always wonder about if a woman's having trouble, is what's the carrier?
May I ask,
sure.
Am I allowed to ask what in the holistic oils that you prescribe that I use, what the carriers are in that?
Yeah, they're a proprietary combination of borage oil, evening primrose, and jojoba.
Evening primrose, do women have any problem with that at all?
Well, au contraire, evening primrose is known to have special benefits for women. It was one of the reasons we chose it. So does borage.
Thank you. Thank you. It was a question that came up, and I thought maybe I could sneak that in really fast.
Sure. You sneak away there, Carolyn.
I'm very sneaky because it's Halloween. I don't even have my ears on right now. I should have, but I forgot them. Anyway, thank you for answering that, because I know a lot of women want to know, what the menopause method oils, have in them, other than some of these other fillers that, a lot of us aren't
pure,
aware of.
certified, organic, borage, primrose, and jojoba.
Thank you. And thank you for that answer. And yes, we do get a lot of women here. We do, you and I, that seem to have this problem with progesterone. Many women aren't even on any of these forums because they're just fine. They're not having any problems at all. But for some weird reason, yes, many women do. And so I appreciate the answer.
Yeah, we might have I'd like to say after 28 years of not only seeing my patients, but training and mentoring physicians and nurse practitioners seeing patients, the progesterone sensitivity is very rare.
Right.
It does exist, but it's very rare. It's not common at all. And I think where I see it, and I can put my finger on a possible cause, is a woman who's had a hysterectomy 10, 20, 30 years ago, and she was told that she didn't need progesterone. False. That's not true. Progesterone is good for all women, important to treat women who've had a hysterectomy. And thus her body hasn't seen progesterone for 10, 20 years. And that's where there's an identifiable challenge with progesterone, but it doesn't stop us. Our ordinarily starting dose for progesterone topically is 200 milligrams per milliliter. It's just over 8 milligrams per drop. Now, if we have a woman who's having challenges, we'll start her much lower than that. We'll give her something like 20 milligrams per milliliter. So each drop contains less than a milligram of progesterone. And have her start with one drop.
So low and slow is okay.
Yes, and keep it low and have her get used to that. One drop a night for a week if she's been having trouble. And if she tolerates that, we'll go up to 2 drops. And gradually over time, her body will become reaccustomed to progesterone, which again, it's very abundant in a young person, in a young woman's body. Far more abundant than estrogen and testosterone and DHEA is, far more abundant. So a woman's body knows the progesterone molecule and loves it. It does so many
Right.
great
Yeah.
things and important things.
Very, very much so. Well, thank you. Thank you for answering that. And I think it's going to be something that will be pursued again in the questions that I receive. My second question is, you might like this one. What is the difference between taking estriol with estradiol and not just estradiol alone? I am taking my estradiol as I read often that estriol does not do much for a woman at all. Could you please explain this and why estriol is a higher dose than estradiol, e.g., biased, please? Thank you.
I enjoy this question.
Yeah.
This estriol, the use of estriol came about because of a very, very special pioneer physician, Jonathan Wright. He's a medical doctor in Tahoma, Washington. And the state of the art prior to Dr. Wright and a pharmacist, coincidentally, in Texas, of treating women in menopause, what was most commonly used was horse urine-derived estrogen called Premarin or Prempro. And when the birth control pill came out, the pharmaceutical manufacturers were not about to use horse urine-derived estrogen for whatever reason. So they were able to extract pure estrogen, pure estradiol. Fair enough, choosing estradiol. That's the most potent of the female estrogens. And in a young, healthy woman, there are 3 estrogens. There's not one. The most potent is estradiol. The second most potent, which is about 80% as potent as estradiol, is estrone. It's more of a carrier hormone. Now there's about 2+ times as much estrone as there is estradiol in a young woman's body. And estradiol and estrone are the potent estrogens. There's a third estrogen. It's called estriol. And it's about 1/8 as potent as estradiol.
Okay.
However, it's more prevalent than the sum of estrone and estradiol. There's more estriol than the sum of adding up the amount of estrone and estradiol. So that's how nature designed the woman. And Dr. Wright, to me in our world, is very famous for saying, look, don't reinvent the human being, copy nature. So one of the things that Dr. Wright did is he knew that there was pure estradiol out there, and he knew it was being extracted by the pharmaceutical industry, and he asked a compounding pharmacist to see if he could get some pure estradiol and put it up in creams and gels and deliver it topically. And because he knew about estriol, he wanted the pharmacist to also include estriol. In the beginning, he included estrone, but that's not needed. So Dr. Wright eventually came up with a formula called Biest, that it contained estriol plus estradiol. And this was in the early 1980s. And why did he do that? Because he just wanted to copy nature, but that wasn't the only reason. There was an oncologist, a cancer specialist at the University of Nebraska, Dr. Henry Lemon, who was looking in his laboratory about were there differences between women who had breast cancer, who he was treating, he was a breast cancer specialist, and women who didn't. And one of the things he wanted to look at was, well, what were the hormone profiles? Was there any difference? And the way he was assessing hormones was by doing a 24-hour urine hormone collection in the late 1960s. Why
Wow.
was he doing that? Because that was state of the art. And when he broke down the estrogens, he learned that young, healthy women had more estriol in their urine than women who had breast cancer.
Wow.
So Dr. Wright found another reason to copy nature, and just follow Dr. Lemon's guidance. And Dr. Wright learned that if you gave about 80% estriol, 20% estradiol, or some variation of that, but the original work was somewhere around 80-20, that you would produce a urine pattern in most women that copied nature. Dr. Lemon found that there was 1.3 times as much estriol in a healthy woman's urine on the average than there was the sum of estrone and estradiol. Well, about 10, 15 years ago, a laboratory commissioned me to repeat that study. And I found that there was 1.1 times as much estriol. So there's more estriol. That's the moral of the story. So why do you want to reinvent the woman? Was Dr. Wright's just copy nature. Well, all this was done in the early 1980s. This is long before we knew anything about the estrogen receptor site. That was in the late 90s. And what was learned is that throughout a woman's menstrual cycle, 28 days, let's take that as an average, that the whole first part of the cycle is prevailed by estradiol. And what's going on in that first half of that cycle, miraculously enough, is a woman is preparing for possible pregnancy. She's preparing the lining of her uterus to receive a fertilized egg. And she's preparing her breasts for breastfeeding once a month. She's getting increased number of cells, breast glandular cells, by cell division, by mitosis. In fact, most women can feel that, of course, over the course of the 28 days, their breasts get fuller. If she does not get pregnant, that whole process of producing extra cells is reversed by a process called apoptosis. Those cells disappear, and she goes through it once a month. If she does not get pregnant, she sheds her whole uterine lining once a month, called menstruation. The orchestration of the female menstrual cycle is staggering. If you don't believe in the divine, just study the female menstrual cycle.
True. That's so true.
And now here's what was learned in the late 1990s, that the whole proliferative phase, where the uterine lining is forming in preparation for receiving a fertilized egg, where new breast glandular cells are forming by cell division to prepare for possible breastfeeding that early on. There's two different receptor sites that guide this process. One of them is called estrogen receptor site alpha, and that promotes proliferation. And the other one's called estrogen receptor site beta, and that promotes deproliferation, the shedding of the uterine lining, the disappearance of the new. Boy, it's almost predictable, the timing of when your cat joins us. Jumps right up in the back of the seat. It's really remarkable. You could set your watch by that cat.
They're smart.
And the whole deproliferative phase is under the receptor site guidance of the receptor site, estrogen receptor site beta. And the prime stimulant of estrogen receptor site alpha, the proliferative, is estradiol. And the prime stimulant of the deproliferative estrogen receptor site beta is estriol. So the reasons were not discovered until 15 years or so after Dr. Wright and Dr. Lemon were proposing that this is the way it should go. So I favor estriol. There was a time, now I don't know what's being done these days, but there was a time in Japan and Europe where the principal hormone given to women in menopause was estriol.
I was going to ask, yeah.
I don't know if they knew the reason. I didn't follow that reasoning, but estriol, we include every time we treat a woman with estrogen, which is all the time, 100% of the time.
Did you hear that, Bijou?
We include estriol, and we start with a formulation of Biest, which is 80% estriol and 20% estradiol. And that will very often produce a hormone in the urine pattern that copies nature. And it'll lean a little bit to the estriol. We like to get a little extra richness to the estriol because it stimulates deproliferation. And we don't want breast glandular cell proliferation, for the most part, in a midlife woman, whose immune system might not be as voracious as a young woman's is to pick up itinerant cells that don't belong there. So estriol, Biest, love it, always include it. Now, when the pharmaceutical industry wanted to work with estrogen, they don't choose estriol. And they have no proof that estriol is not beneficial. I've been laying down the information. I presented this information to the National Academy of Science, how important estriol was. But in medicine, for a wide variety of topics, it can take 3 decades before the best scientific information is deployed. It's very common. So it hasn't been 3 decades. It has been 3 decades.
Well, yeah, I mean.
But they'll catch up with it. Sooner or later they'll get it. And, there's several of us who have been teaching this. So hopefully it'll filter its way out into the public, including a great deal of teaching about this by Dr. Jonathan Wright.
He's written some books too, so I guess.
Oh, yes, it's in his books. It's in the books he wrote with Suzanne Summers. So read our book, Happy Healthy Hormone, that Carolyn's made available as a free PDF version on the Facebook page, Ins and Outs of Menopause, where I go into this explanation in a little more depth in our book, if you want to know more about it. So that's why we use estriol.
Got it. One last question on this one. I mean, would it make any sense to use just estriol alone without any estradiol?
Well, if you were just thinking about it, you could say, well, maybe that's the best way to go. But there's an intricate biochemistry.
That one.
That I also show in the book, that if you give too much estriol, you're going to distort the normal biochemical processing of the estrogens
Got
by
it.
the law of chemical mass action. Need I say more? But that's the technical answer why we do not give pure estradiol. And sometimes, even though we start out with a formulation of 80/20, when we do a 24-hour urine at the 2 to 4 month mark on a woman after she's found her optimal dose clinically by symptom relief, we find, oh, there's a little bit too much estradiol. It's interfering with her processing. So I'm not going to go deeper into that unless you ask me a question about it or our audience asks a question about it.
I need to
But
go
that's
through
why we don't
a
use
little
pure
bit more.
estradiol, because we can't produce nature. We
Right.
can't produce the biochemistry of how nature does it for women. So we will change the ratio sometime if we see that there's a little bit too much estradiol. The law of mass action is taking place here. We don't want that because we
The
really want.
law of mass action.
So that was a great question, Carolyn. But that is the answer why we don't do pure estradiol.
And it's a great answer. It is, because I think that yeah, it answered the question. So in so doing, I can ask question number 3, and I do see this question up here. I'll get to that. I have watched the video on titration, and I'm wondering how titration can be done so quickly. I'm really confused by this. It would seem to me that it would take a woman months to titrate her hormones to what is optimal for her. Can you explain this, please?
What the questioner is referring to is let's take a woman who's 52 and she hasn't menstruated for 2 years and she hasn't been on hormonal treatment. And she's got symptoms. She's got hot flashes. She's having trouble sleeping at night. She wakes up with racing mind and pain on intercourse and all the long list of symptoms that will occur from estrogen insufficiency. Well, we're not going to just make a guess at her dose and say, here, take one pill and see you next year. No, we're not going to make a guess at her dose, and we're certainly not going to use an estrogen pill. We're going to start her off on what we suspect to be a low amount of hormone and have her gradually increase over time. And we've got specific schedules by which we do this. But we have to make a choice with the woman between 3 different schedules. Some women, we want to go really low and slow. Some women, there's an average amount where it's the most common starting dose. And there's a titration schedule, and here it is. There's week 1, there's week 2, there's week 3, there's week 4, and we're gradually increasing by 1 drop, either in the nighttime or in the morning, the estrogen in each week. And so how did we arrive at that? By 20 years of doing it. There's no accident on how these schedules got produced. Again, some women, we go slower. We call it the lighter starting dose. They're starting at half the amount that the most common women are. Some women, we go faster. But usually, even if a woman hasn't seen hormones for a couple years, at the rate that we've designed these, and physicians and nurse practitioners have a choice, which one of these 3 starting protocols do they want to choose? Slower, lower and slower, or a little enhanced, and anywhere in between. That particular 1 month of finding the right dose, it, practically speaking, it works terrifically. It's not too fast. And I'm saying it's not too fast for 95% of the women. Oops, there's always exceptions. So if a woman gave me a hint that it wasn't working well, and like, for example, if this woman said, well, gosh, I'm doing your titration schedule, but it seems too fast, what I've learned to do is listen. Okay, it seems too fast. Let's go slower. we're going to customize yours. So you're not going to increase by a drop except every 2 weeks or every 3 weeks. Now, how often do I hear that this is too fast? Almost never. But there's always exceptions. There's tremendous variation of us as in individuals. There's nothing wrong with it. You're going to be perfectly happy and need a slower, healthy and happy, and need a slower and lower titration schedule. Or you can be perfectly healthy and really prefer to have a more robust titration schedule. The trick is individualization.
Right.
So obviously for this questioner, she was pushed too fast. Or her intuition says that our schedule is too fast. So, duh, when a woman says, that feels too fast to me, say, no problem. This is not an emergency hypertension medicine. I'm happy to go as slow as you want. And how did I learn to do that? Because I paid attention to what women's input was. And I learned, hey, just pay attention. Just do it. In many instances, do what they feel is right. If it's variance from what you think is right. And, at least we're doing a trial, a clinical trial. Maybe she's right. I do this all the time.
Right. So, I mean, would it stand to reason then if you've been taking these for like 4 years, 5 years, oddly, you're feeling a bit off, would you be able to take like a half a drop or a drop here and there to sort of balance yourself out?
And that's a goal that we have, that if a woman can adjust her dosages, because for one thing, a man or a woman's daily hormonal needs are not identical and precise day after day after day. For example, if you have life challenges, known by some as the word stress, you're going to need more hormones, of every hormone you can name. They are recruited for the fight or flight, and you're going to need them and want them. So your daily needs vary. So one of the purposes I wrote the book was to get a woman familiar enough with what's going on and how to adjust so she can individualize it, customize it for her needs, and have some variability. She goes through, you get a relative who's ill, your life's not going to be the same, and your biochemistry is not going to be the same. You may need a drop or two more carrying through that illness in the aftermath of it. Just to give you an example. So we are right out of the gate. I thought, well, these hormones are going into an individual woman's body. Best case scenario, she gets a feel for it and can make adjustments. I don't recommend that overall with some medications.
Yeah.
You got someone who's got a very high blood pressure, and it takes a while to figure out what medications does it take to get it down. I don't say, why don't you just play with your
No,
dose?
no.
No, there's some medications that there's very strict protocols for good reasons. But it's not so in the world of hormones. Worst case scenario, you forget your hormones. There's no urgency here. Or quote, worst case scenario, you take a little bit too much. Oh, well, you just back it down or stop it for a while. These are not problematic.
Right. And it's not a huge like withdrawal, horrible.
No, precisely. Good point. That word withdrawal does not apply. If you stop all your hormones, you're not going to go through a withdrawal process. You're eventually going to feel, once again, the symptoms that come from insufficient hormones. But that's very different, and good for pointing that out, Carolyn, than withdrawing from a drug too fast, for example.
Right. It's a big fear that
Well, it's not. You can miss dosages. You can you can take an extra drop or 2 or 3 or whatever. It's just not going to make a difference for 99% of the women. You won't even notice it.
Yeah, it's amazing to me. It allows women, I believe, to have a say in her own menopause and kind of take her menopause back into her own hands a little bit to be able to titrate up a drop, maybe titrate down a drop, maybe, you know?
Precisely. Want that.
Yeah. Yeah. And it doesn't have to take months and months and months and months
No, it doesn't. It
right.
doesn't. Most women, if a woman hasn't seen hormones for a while, usually by the first month, she's starting to get a handle on things,
Hmm.
especially if she's got a partner, a medical professional who's there's a frequent enough contact consultation that process is guided. And I always think in terms of somewhere between 2 and 6 months that it's going to take a woman who hasn't seen hormones for a while to dial it in to the optimal dose. And so we don't test. It's very rare that I'll test before the third month, because when do I want to test? When a woman says, wow, I think I got my dose. I feel better. And I think I found the right dose by titration, which is that process of gradually increased dosage until you alleviate symptoms of insufficiency, or if you've gone too high and you get symptoms of excess, of backing down. You know, that question from Melissa, I think, would you read that one, Caroline?
Yeah.
I think we should take it.
You read my mind
All
yet
right.
again. Hi, Melissa. Good morning. So, I've been reading comments about HRT causing ovarian cancer. I've heard about the breast cancer risk, which I know is low, but not ovarian cancer. I've never heard this question on our Facebook Live.
Yeah, and it's a good one
Mhm.
because these kind of rumors are out there. And I would like to clarify this one. You know, as a medical doctor, I was trained and educated in the thousands of diagnoses, medical diagnoses that can happen to us as human beings, many of which are not pleasant and some of
Mm,
which are really rough. And amongst those diagnoses, there's hundreds of cancers that we're subject to. As a male, I have a particularly increased relative risk for prostate cancer, and there are reasons why that is so. And women have an increased relative risk of getting breast cancer over other cancers, and there's reasons why that's so. Now, ovarian cancer is far less common. So we're all at risk for cancer. And cancer is caused by things. In fact, the way I like to look at it, and I've said this many times, is I'll explain to a patient who's got any diagnosis. I say, let's pretend that your whole life was videoed from the time that you were conceived and in your mother's womb till last night, 24/7. And let's pretend that the videographer had a magic editing button in which they could edit out all the good stuff, all the healthy food you ate, all the good exercise you did, all the care you had to not get exposed to toxins, and all the tremendous amount of information and tools that you acquired that made you an expert at the stresses of life so that you could handle the stresses of life mentally and emotionally and through choice, and never triggered the biology of the fight or flight. What that magic editing button done is it got rid of the causes of all illness: dietary indiscretions, toxic exposures, too much or too little exercise, or the elephant in the room, an over response to the stresses of life, which triggered the fight or flight biology, which is really a problem over time, not in the short run, but in the long run. Those are the causes of all illness. There's a fifth cause. There's some mysterious causes that things are not explained by ordinary means. So the videographer edited out all that stuff and then sort of showed over my shoulder here on the wall a video of everything that remained. There we would see all the marginal choices or deleterious choices you made about what you ate, all the toxic exposures that you breathed or were on your skin or in your dry cleaning fluid, or this is the age of toxic chemicals. It's and they just come in one molecule at a time. And it's not like you drink a bottle of arsenic and you keel over, or hemlock. It's like but they add up. And all the dysfunctional responses to stress. Those are the causes of illness. Those are the causes of serious illness. Those are the causes of cancer. And when you look at any given patient, there's thousands of events on that ersatz film that I'm talking about, the video. Now, hormones do not cause cancer. They do not cause cancer. So this statement in the question is that I've heard about the breast cancer risk, which I know is low, about HRT causing breast cancer. That is untrue. That's not true. I know where you came from. There was this Women's Health Initiative study in 2002 that was published that falsely published a statistically insignificant result. And it just spread like wildfire, and it terrified women all over the planet Earth and healthcare providers. It was false information. It was even admitted by that study committee that it was false information. They sort of admitted it. But in 2017, they published in the same journal, the Journal of the American Medical Association, that they published the original article in, that after 18 years of follow-up, there was no increase of breast cancer, heart attack. Ovarian cancer, breast cancer is not caused by hormones. And even the growth is very marginal, whether it's facilitated by hormones. There's a whole argument that it is not. So I wanted to clarify that. And here's the science as beautifully described in a book called Estrogen Matters. Maybe you'll publish a link for that.
Oh, it's everywhere. Please no.
Okay. That's Avram Blooming and Carol Tavris. Dr. Blooming is an oncologist who specialized in breast cancer and treated women with Premarin and Prempro. It really exquisite story of that, and here's what it amounts to: that women who are treated with hormones, here we're talking about Premarin and Prempro primarily, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. Women who've had breast cancer and have had that breast cancer properly treated, they're at an increased relative risk of recurrence than a young woman is of developing cancer who's never had it. But the women who are treated with hormones who've had breast cancer are at less risk for recurrence than women who go untreated, do not get treated with hormones. Now, it's even more so the case with ovarian cancer. The hormones do not cause cancer. Ovarian cancer, breast cancer has causes galore, as does any serious illness. But the science is that women who are treated with hormones are at less risk for these illnesses than women who are not.
I thank you for that. If I could do every interview starting off with just those sentences,
Yeah.
I would be thrilled. Really.
It's so important to dispel that myth, because the consequences for a man to not be treated with hormones, and I know we're not talking about men here, or for a woman to not be treated with hormones, that is tremendously consequential for bones, for vagina, for muscles, for brain, for arteries. It's tremendously adversely consequential. There's almost a guarantee that very serious problems are going to develop. And they come on gradually for most folks. But I can tell you, having experienced working with women in their 80s and their 90s, that their life is just as important to them as a young woman's life. And there they are. If for the ones who haven't taken hormones, they've lost their muscles, they're getting into canes, walkers, wheelchairs. They've lost their bones, so if they fall, they get a fracture on an osteoporotic bone. They've lost the protection for their coronary arteries, so they're, although they were protected against heart attack as compared to young men by their estrogen, they lose that protection, and half the women who leave the planet Earth do so by some complication of arteriosclerosis. Many women develop serious cognitive issues. Even some develop dementia from not having the estrogen, mood disorders, sleep disorders. It goes on and on. So one of the reasons it's so important for me, from me personally as a medical doctor, to dispel this myth that hormones cause cancer is because the consequence of not being treated with hormones, well, in many cases, it's just devastating. If anyone's had a mom who got dementia, now not all dementia is caused by lack of estrogen, but there's a significant amount that is. Or a mom who's had to go into assisted living facility because she couldn't control her bladder anymore,
Mhm.
couldn't walk. She had to transition from a walker to a wheelchair. Anyone who's had a mom who's had to leave home and go into an assisted living facility or nursing home. God bless the assisted living facilities and nursing home and the workers that are it's amazing phenomena. But I can tell you about the women that I've worked with, they would prefer to not make that transition. And the major cause of having to go into an assisted living facility, not the only cause, but the major causes are lack of ovarian hormones. So it's not just this idle question about, well, I just won't take hormones. Yeah, almost a guarantee that you're going to develop loss of muscles, loss of bone, loss of arterial protection, loss of vagina, loss of bladder control, loss of your ability to think clearly, et cetera, et cetera. Because these hormones are the most powerful biochemicals in our body. And they do big things. And when they're gone, and they are gone at menopause for women, the consequences are very high. So,
We
words to the wise,
yeah,
get thee to a hormone specialist.
it's magic.
That's your main job. You don't have to go to medical school. You have to go shopping to find a physician or nurse practitioner, or in some states, even a compounding pharmacist that has studied this, knows it, is primarily focused on treating women in menopause. That is your job. You find the provider. They'll do the heavy lifting, and you'll do it as a team.
And when that happens, it's like nirvana.
Yeah.
Really, it is. And there's help and there's hope, and it goes on and on and on.
And you stay on them for the rest of your life.
Right, because we
Try and tell me to stop taking my testosterone, or try and tell a man that, well, you don't need those hormones. You're old. You don't need them anymore. Yeah.
Right, wrong.
Wrong. I'm never going to stop. So long as I can open up that top, unscrew that lid.
Or you're going to find someone to do it for you.
I'm going to ask someone to do it for me. Yeah.
I know, that's what I would do for sure. So that's always such a great subject to talk with you about. I'm going to move on. We have a few more minutes. So this is question number 4. And this woman says, because it ties into really all of this, I've been using HRT for 25 years. I'm 65 now. And I'm wondering, when will I stop menopausing without symptoms? My friends are all done with their symptoms, and I can't figure out how this can be. What do I do?
Take them for another 25, 35, or 45 years, just as you're doing. And I've always felt, not always, but it didn't take me long to see that the best case scenario for a woman is that she had raucous, life-stopping symptoms.
Ugh.
Because these are the women that are inspired to do something about it. And the women who say, wow, I made it through menopause, piece of cake. I don't understand why everyone's complaining. These are the women, and there's only 25% of the women who go symptom-free. And but 75% of the women have small, medium, large, or humongous symptoms that just slow down everything. It's hurdles galore. I've always considered them to be the fortunate ones.
Yes.
So celebrate it that you're getting a lot of feedback. Like if you stop those hormones and you get symptoms, you're the lucky one, because best science is you take these hormones every day of your life. Now, we see our patients, we could do a consultation annually just to check them on them, make sure the dosages are right, and make sure they test out properly in several different ways. But it's very unusual that we have to do major changes of any kind.
Right.
In fact, it's very unusual to make even moderate changes to their program. So that's the best science. Because, like, for example, a woman who's taken hormones for 25 years and have protected her bones from bone loss, just as one symptom of many, many possible symptoms. The day she stops her estrogen, she's going to start developing bone loss, and it's going to be rather rapid. Doesn't matter if she's 90 and she's been taking hormones for 45 years. The day she stops her estrogen, all of a sudden she's going to start losing bone. What about arteries? What about mental function? What about sleep? What about mood? What about vagina? What about bladder? What about muscles? Because you should be on testosterone too. All of these things. So my best recommendation, that is highly educated recommendation and highly experienced recommendation,
Those
is
books were heavy.
get on a good hormonal program and never take your foot off the gas.
I got to tell you, that's
Mm,
my thinking for sure. And I did my due diligence, trust that, in doing the
mm.
doctor shopping, and I got very lucky. Um, well,
Well,
you
my
know what?
goodness.
I know I got to save this
Naseem,
question.
hello. Welcome, Naseem Tariq. Oops, probably shouldn't have said your last name, but welcome to you.
Well, it's
And the
showing
time,
right there.
yeah, the time is arrived.
It has. We must say goodbye. Till next Tuesday. Dr. Rosensweet, you're amazing. And I tell you that all the time, so you have to know it by now. What, 3 years later, 4 years later?
Mm.
Um, thank you. Thank you so much for a really nice interview. Truly.
You're welcome, Carolyn. Yeah,
Uh,
always a pleasure.
always a pleasure. And the cats love it for sure. We know that, right? Indeed. I'm going to wish you a wonderful week, wonderful weekend. Same to everybody else. Send in the questions. I've got them. I'll copy them. I'll ask them. And we will just keep it moving from there.
Mm.
Enjoy,
Bye bye, everybody.
everybody. Thank you.